Um, Hello, my name's John Goodhead. I'm one of the prescribing students, and this is my DBP, Dr. Singh.
My name's Dr. Singh. I'm a gastroenterologist at Bassett Law Hospital.
And this is our case-based discussion. We're discussing a patient who came into clinic recently complaining of reflux symptoms. She's been suffering with them for about a year. GP has put her on a PPI, a omeprazole, 20 milligrams BD, but despite this, the patient is still complaining of heartburn, so they've been referred to at the clinic. Firstly, went through lifestyle with the patient. Checking, for instance, her weight, because higher weight can be increase the heartburn issues. On a questioning, she drank 2 to 3 glasses of wine a night, which is above the recommended 14 units for the lady. She also smoked as well, which is another one of the risk factors. So I then went through various triggers with her to see if any of these were relevant. In terms of medications, she wasn't on any non-steroidals or biphosphonates because she's only in her mid-40s. She has high blood pressure, so she is on amlodipine, which along with nitrates can potentiate the symptoms of heartburn. Also went through her meals, what time she has her meals, and whether she takes any of the other triggers such as coffee, chocolate, tomatoes, or spicy food. So we, at that point, went to do a abdominal examination to rule out any masses, or we were looking for things such as Virchow's node, or whether she was suffering from anemia.
Before we get onto that, John,
Mm-hmm.
do you think lifestyle changes make much of a difference for people with reflux?
It makes some changes. I feel it don't make a hugely significant difference.
And I mean, in my own sort of experience, it's often the case that people find it very difficult to alter their lifestyle. So weight loss is easy to say, but difficult to do. A regular 1 or 2 glasses of wine in each evening, often patients don't think is relevant, but it often is. But yeah, I think you're right. People often find that lifestyle changes don't really help as much as you would hope. Yeah, sorry, carry on.
Yeah, so, I mean, I could go through, like I said, we could go through the lifestyle advice, which is to try and avoid the triggers where possible. If we find that she was having meals late at night, we could have suggested to move the last meal forward so she has a good 3 or 4 hours before she goes to bed to help with the nighttime symptoms. And also, because she's on the omeprazole, I would be checking to see when she's taking it relevant to her meals, because we'd like her to take it half an hour before the meal rather than with the meal, and just in general see whether her compliance, whether she's just taking the morning dose and forgetting about the evening one. We'd also went through looking for any potential red flags, such as unexplained weight loss. If we were looking at 10% less, 10% drop in about 6 months, that would be setting off urgent referrals. If she had any black stools, family history was one which she didn't have, but that would any family history of esophageal or gastric malignancies would also come up. We'd also took a full blood count. We were looking for falling HB, so looking for symptoms of anemia, or if the platelets are raised, we'd be showing us signs of bleeding or possible gastric malignancy. Also checked to see whether she had any pain with this, which she didn't, and whether the symptoms were progressing, which is also another red flag, but in her case they were not. They were fairly consistent over the last year. So in terms of investigations, we requested whether she had had a H. pylori stool antigen test by the GP, which she had, which had come back negative. We checked that whether she had had her washout period of her PPIs, because she would need to be off them for a minimum of 2 weeks.
Do you think that was the right thing to do when the GP asked for a H. pylori stool test? Was that the right thing to do, do you think, for this group of patients?
I think it's an investigation which needs to be done.
Yeah.
Some patients are not particularly compliant with stopping the PPIs for 2 weeks, because if they feel that's the only thing which is helping them, they
Yeah, no, I think you're right. And do you know if there's any sort of specific guidance out there for GPs or primary care teams?
well, there's NICE guidelines and the MRHA, which talks about 2 weeks without the PPIs. Also, if they've had any recent antibiotics in the last 4 weeks, that can also give a false negative.
Yeah, NICE did produce guidelines on dyspepsia. They're a bit old, but I think that's what GPs tend to follow nowadays. Okay, sorry, carry on.
All right. So, because she had had all the tests, and we weren't, even though there was an absence of red flags, still was a referral made for an OGD, and we'd be looking for things such as hiatus hernia, Barrett's, see if there's any changes in the cells of the food pipe, esophagus, looking to rule out malignancy in general. This does come with a risk. It's around a 1 in 10,000 chance risk of perforation for a routine OGD, which, considering her age, was considered reasonable. If she did show signs of Barrett's, for instance, we would have to keep repeating these every 2 to 3 years until she was around 75. So if the OGD was normal, the next steps are a series of options. We could consider switching the PPI to another preparation. Some evidence that people become tolerant to it if they've been on it for a year.
You don't know of any side effects or that PPIs can give?
They can cause GI upsets. You can have diarrhea.
Diarrhea, yeah.
That's quite a common one.
Have you heard of any electrolyte abnormalities that PPIs can cause?
They can drop the sodium as
Yeah.
well, which so whether
There's 2 electrolytes that can sometimes drop. Occasionally, very rarely, sodium. There's also another electrolyte that do you know what I might be thinking of?
Magnesium
Yeah. So
can drop
very,
as well.
very rarely there is some association with magnesium drops. Any other sort of long-term risks of taking PPIs that we know of?
They can. I thought there was an issue with. I'm thinking bone protection.
Yeah, no, there is some very weak evidence, but it's persistent, that long-term use of PPIs can possibly cause a bit of osteopenia, but that's very long-term over many years. Sorry, you're talking about the options. So you mentioned switching the PPI.
Switching the PPI.
Yeah.
Another option would be a H2 antagonist, such as famotidine. This can be quite useful if they're suffering with nocturnal symptoms. So if they take it just before they go to bed on an empty stomach, that can often be added into the situation. We could try an alginate such as Gaviscon or Peptac, either on a PRN or regular basis. The amlodipine, because that can increase the chances of reflux through the side effects, we could consider altering that and switching to something like a Ramipril or something which wouldn't have the symptoms. We could go through again avoidance of the triggers, such as try and reduce the smoking and the alcohol intake, and if there's any trigger foods from that aspect.
The other trigger I often find is fizzy drinks, because they're very acidic. But yeah, you're right, smoking, alcohol are the main ones as well. Any other options to try and improve reflux? Let's say PPIs don't work, H2 antagonist switch doesn't work.
We could add options such as domperidone or metoclopramide, which are prokinetics, so they would help with the gastric emptying to reduce the symptoms from that side.
And are there concerns about using those drugs?
The domperidone they prefer only to use for a week at a time, because it can increase the QT interval. So if you were to carry it on longer term, you need some cardiac monitoring. Metoclopramide can cause, it can potentiate I think what the terms, the peripheral side effects can affect Parkinson medications.
Yeah, so it can cause neurological side effects. That's the concern if it's used long term.
And those don't tend to be reversible even if you stop it.
Correct. So it can sometimes be irreversible. So we tend not to use long-term metoclopramide. That's right.
Okay.
So let's say you've gone through that process and the triggers they've avoided, and they've, the PPIs haven't worked, the H2 antagonists haven't worked, the alginates haven't worked. The patients don't want to go down the route of the risks of the prokinetics. Any other options for this group of people?
Ultimately, you could refer them for anti-reflux surgery right at the end.
And surgeons sometimes take them on, they sometimes don't. Sometimes they prefer patients to jump through loopholes, so if they're overweight, they want them to lose weight before they consider surgery. So that's not always a final solution, but that's right. And fine, I think that's it, unless there's anything else that you want to...
No, that's it.
Okay, fine.
Thank you very much.
So we are going to go on to the examination.
Yes. Okay.
Okay.
All right.
Thank you.